I'll try again. I've got about 19 minutes, and you're going to have to keep me tight on time. So I currently I'm the CEO of 3 small companies today. I've spent 25 years in health and care and data, and I'm about to build my 4th. I'm going to ask you as an audience to help me out right now. So here's the question. I'm going to show you some evidence of what capabilities are around data, not just for mental health, but right the way across the system. And then I'm going to tell you about what we're building towards. And what I'd like to ask you as an audience, whatever your interest is, what would you use that data platform for? So this example is the Discovery Data Service, which is in use today. It's been running live for 4 years. It's one of probably Europe's largest real-time databases. It serves 3 ICSs in London today. And just a couple of stats. So this was Friday afternoon. And it just talks about the 3 ICSs that we're serving, the sort of tools they've got, the data feeds. Sorry, absolutely not the sort of screen you meant to put up for an audience, way too much detail. But I wanted to talk about just one example on this screen. Every time you call NHS 111 in any of these 3 ICSs, they call what we call a frailty flag. So that alone, whether it's London Ambulance or NHS 111, that alone, last month, 700,000 people went on a different care pathway from one point of data. In total, increasing by 400,000 last month, we're amalgamating 34 million patients' records. That's across a population of around 7 million citizens in those 3 ICSs today. So this is real time, this is live. And we are serving data from 5 major acute services, over 800 GP practices, and there's around another 150 other types of data sources, whether that's mental health, out of hours, etc. I'm not going to labour these points, and I don't expect you to be able to see them, but these are the actual organisations that data is coming live from. And when I talk about the data, I'll come into it a little bit more. So primary care, secondary care, community, these are live examples around London today. Just to put some scale onto this for a second, this is a measurement over a rolling 12-month period as of Friday, and that period has had over 288 billion calls on that data. A couple of months ago, it was actually up at 400 billion. So I'd like to say this is a tried and proven system. It's secure. There have been no data breaches. The average number of daily calls is nearly 800 million. So that's the evidence. That's just one area. And that data is collected from all those different sources, and it's a different approach to interoperability and integration. My friends and I have tried to crack interoperability for 25 years and standards, and we know it's good work. We've tried several initiatives to make it better and faster. And actually, I'm standing on the shoulders of giants who said, why don't you just give us the data and we'll normalize it? So that data is patient identifiable, it's real time, it's normalized to SNOMED CT, and anything that can't be normalized, we have what we call an information model. And we have over 2 million terms of ontologies and concepts in that. And here's the thing. All of that work is completely open source for anybody in the world to set that up, take it, and use it. So I'm going to talk a little bit about, this is my second presentation, if I'm good for time. So I set up my own consultancy 4 years ago, having spent 25 years in the industry. And really what it's about is health, tech, and data strategy. And it's taken me 4 years to come up with this, and this is the aim of the next stage of the work of all of the companies and a consortium of people that can access. And it's called Unifying Patient Data. Part of the problem, of course, is we don't have joined up clean data. So here today in this stream, it's about mental health. But because we don't have mental health people, we have people with multiple conditions. And no matter the strategies in this country right now on data, I don't see one that's quite all amalgamating. So we know that not having the right data at the right time in the right place for the right people does cost lives today. That affects all of our commerce, the time we've got to take off, the issues, the delays in care. We talked about 7 million people being on the waiting list. In truth, only 4% of those people will ever need an overnight stay. But we need to get through the data. 50% of the people probably shouldn't be on that waiting list, and 25% of people have probably got mental health issues, but they're not seeing the right people for them. So we know a lot about what's in the data, but we can't necessarily get to it. There's just a couple of examples. So not having the right data causes mistakes and complications. I'm probably not telling you anything new here by any means. But the project to unify patient data will complement all existing NHS strategies, but it's not a strategy that's public. We will be able to deliver faster, better data, and it will complement the new federated data platform. And let me tell you why. And anybody who was aware in the last few years, EY was commissioned to do a report, and it can release savings about 3 billion per annum, but actually probably the data itself is worth about 4 billion. They reckon it's sort of 9 to 10 billion. And partly that's what the FDP business case was built upon. The same applies to this. The thing with what we do with this data, based on the example I've just shown you in London, is we take real-time direct care data and it's used for multiple reasons. We then de-identify it for item number 2, which is population health. And that same data can be used for research. It's not 3 separate data sets, it's one. And then the last one is planning. It can be used for all kinds of things. There's no limitation to what the data can be used for. But this is what we like to build. This is what I'm aiming now to build. And this has taken about 4 years to come up with. So item number 1, structured data, that's been done and not a lot of people know about it. So it's working live in 3 ICSs in London. By the way, we would really love to have 42 of those across England, a Scottish one and a Welsh one, or multiple ones. There is no limitation to size, either small or large, for those instances, and they can be set up really quickly. You can be up and running in weeks. So we take live structured data, as I've given you an example of now, but then 70% of data on citizens is unstructured. And of course, there's an amazing amount of value in that, which can be, especially using natural language process, which can be assessed. Adding in real-time diagnostics, these first 3, they are kind of being done in certain places. But getting through that waiting list example alone, and the patient's involvement as well, want to see what's happening with their diagnostics as well as their diagnosis and other things. But then the last 4, multimedia, so anything that involves you, your consultations, your videos, it could be your theatre operation, it could be with mental health solutions that you are talking at a time that suits you into your record, that you want to play that back, and you want to pass that on to your carers. And then your DNA and the genome. Now, there's a lot of work going on about bringing those together. But what if that was brought live to you as an individual and your patient record, and then placed wherever it is you're in the country, that we could know, one, where you are if you choose to tell us, I say us as in the care system, but really importantly about where you could go next. So if you are in urgent care, or if you are in A&E and you go into the hospital, where can you go after the hospital? We know that 25 to 50% of people in the hospital today are actually medically fit to discharge, but we don't know where all the care home settings are, or if that person could go home and the carers are there. So it's not joined up, it's not ubiquitous across the land, this live real-time information. But the last one, which is probably the single most important one, and it was mentioned in the talks this morning, is your individually generated data. Whether that's from your wearables, whether that's from your implantables, whether it's from your apps, any data that you want to share. And that's what we're going to build, is so that that is quite uniquely secure and available for multiple uses. I won't labour some of the points, but I'm hoping what we've started to trigger off now is, what could you do with this type of data? The thing we guarantee with all of the people that will be provided with this is particularly guaranteed interoperability to get that data and security service grade cybersecurity. The people we're working with work with our national security services. And here's the thing, we can start this off at 50 pence per citizen per annum. So whoever the budget holder is, almost doesn't matter. And it's relevant to your part of the world, wherever you are. If it's inner city London or if it's Grampian in the borders, it doesn't matter. Because we've done the numbers and we know how we can commence this service. So, with 7 minutes to go, if I may, I'd like to invite you to tell me, what could you do with this data? Or, if you've got any questions. Thank you for your attention.
Thanks very much for a really interesting presentation. I guess my question hangs around the ethics of the work that you're doing, and how do you protect someone's data being used unethically or preventing future insurance being gained, health insurance, etc., when you have such a huge abundance of data, which obviously it's anonymized for academic research, but as it comes in isn't anonymous?
Okay, that's a really great question, and thanks for raising it. So it's not my data, it's not my company's data, it's actually owned by the people, if you like, the commissioners of the service. So this will always be a publicly provided service. We only provide the technology and the capabilities. So it's just as it is now, how your data is protected right now will stay the same. There is a health bill going through, which through Parliament over the next year, which is addressing all of those sorts of concerns. So we are effectively a custodian with our technology, but we, like anybody else, and I've been in business for 25 years in health technology, I've never had legitimate access to people's data and records, and never will have. That's not our job. We have people who are trained to help with queries and problems every single day, but it's exactly the same as it is now. So, you know, it's absolutely vital that people understand your data, it's down to the government, it's down to the constituent bodies that commission this type of service. We can guarantee the security and the governance to a point. And I say to a point because we're all as vulnerable as somebody leaving open either their laptop or sharing a password when it comes down to it. But actually for the governance issue, it's a legal and it's a country one. I hope that helps. Anybody else? Sorry, did I see a hand?
Hello, thank you. I think there's a lot of power in data, and I would love to ask or explore how can this public service data be better integrated with private organizations? So not necessarily private health institutions, but you know, any employers who obviously have a responsibility to their employees to create healthy working environments. And is there a possibility to then map the data from employers in specific regions to some of this public healthcare data to better understand the impact of the specific environment and living conditions, social environment on health and well-being of individuals?
There's a lot in that question. Let me just try and unpack. I took about 3 parts to the question. If I may, I'm going to start at the end. So one of my passions was to try and fix the problems where the lack of data in social determinants of health, like the example that was given this morning where, you know, somebody who's got quite a chaotic lifestyle is quite ill but lives in a damp house. Actually, if we started with some of the social determinants of health, then actually we limit some of the other challenges. And I find it really difficult to look across the system of the NHS and care and find out where that work really is. Some great work been done by Dame Sally Davis when she was Chief Medical Officer and Dr. Johnny Pearson Stoddart about how to move that shift and how to measure it. I'd like to think what we can do with the data is provide it for the people researching in those areas. Some of that research in London is being used by Queen Mary's University on some of those sort of areas. If I unpack the other 2 items, so the whole idea of what I haven't gone into today is there's about 60 or 70 use cases already with the data in London, and it is pretty much unlimited. I'd say probably 50% of them are actually research right now, but it's because it's not been promoted yet that this kind of data is available, and that's what I wanted to spark off is what would you do with the data? So I think the answer is the data can be provided, but I'm going to come to your first question is who's commissioning that data? And I don't know the answer to your question as to the employers as who they would be. We've really designed this so it's going to be used by public sector. However, just on the private health, about, 10 to 15% of healthcare is provided privately in the UK today, but all of that data is pretty much not joined up. It's pretty much siloed. But we're siloed inside the NHS and care anyway. There's over 10,000 organisations and there's hundreds of thousands of systems. So my ideal would be that anywhere you go for health and care, your data is either being fed into it or it has the potential to be so. There's lots of privacy issues around that. So I really don't know how to address the idea of the question. I think that's probably for other people to have a go at. But technologically, the richness of that data could pretty much be used for almost any kind of research and query. just back to Voror, what we're doing this year is on top of that, we've just built a prototype query editor. So you don't have to be a scientist or a technologist to go in and write a coded query. You should be able to just type that in and it should kind of come back. And then we'll provide drill down capabilities into that data as well. But you'd start with it being anonymized. You could see an influx of the types of calls that are coming into NHS 111 or London Ambulance. And then you could drill down into the population and then into an individual if you have the right levels of security. So it has quite a lot of capability. Sorry, that's a very long answer, but it was quite a good question. Thank you. Anybody else before I hand over? Thank you.
One thing I wonder is about feedback, so patient feedback that could potentially be, okay, there's a treatment that has happened, and then maybe following up and then bringing back into the database, okay, this worked really well or it didn't, and then that can then help inform for other people in similar situations. I wonder if that's also one of the use cases.
So thank you very much for your question. I hope that's the sort of thing we absolutely can facilitate. The whole point is, I think at the moment there's a lot of individual patients or citizens using own applications, and some are formal applications, like in maternity and with newborn health. There's a lot of that, but it's not always joined up. That's just one example. But I see no reason why any data and any feedback, because ultimately, I think over the next 10 years, we won't be talking at system level about structured data and diagnostics. I think we'll be coming from the citizen, and it'll be coming outwards. And the citizen will be driving their care more than the system is driving care at the moment. So I think, it's a perfectly great example, and I hope that there'll be 1,000 more questions of could we do this when you've got the capability. Thank you very much for indulging me. Thank you for your patience. I'd now like to hand over to